Okay, so there it goes. Okay, so here are my disclosures and the learning objectives that you all have as well. And this serves as a good overview of the talk today as well. So I'll start with just an overview of the biology of liquid biopsies, and I'll be speaking mostly about circulating tumor DNA, but putting it in the context of a broader liquid biopsy discussion as well. So circulating tumor DNA, as it sounds, is DNA that's derived from tumors and is present in the circulation. It can be isolated from peripheral blood, plasma, or serum. And it's distinct from circulating tumor cells, which are intact cells also found in the circulation. Now, both of these can be found in a variety of bodily fluids. In particular, circulating tumor DNA is, although primarily analyzed from the blood, it's also found in stool, urine, pap fluid, cerebrospinal fluid, and other bodily fluids, and that may influence the clinical utility in different contexts. So certainly, circulating tumor DNA is just one of a number of biomolecules that are collectively referred increasingly as liquid biopsies. And that includes, in addition to the cells, it also includes circulating RNAs, even proteins. Some people are now referring to these as liquid biopsies. So the definition has been kind of expanded over time. But there's certain advantages that I want you to recognize with regard to circulating tumor DNA that's generating a lot of the interest in the field. So for one, there's now standardized ways of collecting and storing blood for ctDNA analysis. And certainly there's linkage to genetic and epigenetic information, and we'll go over some of that in this talk. And increasingly, there are commercially available either research grade or increasingly clinical grade analysis platforms that is making this an attractive area. Now, the challenges for ctDNA is that often, especially in early cancer stages, this is a needle in the haystack problem to distinguish the tumor-derived DNA from other sources of cell-free DNA that's present in plasma. So there's low fractional abundance of tumor DNA within plasma. And in addition, it's obviously a challenge to take too much blood from patients. We don't want to do that. So that also limits some of the capabilities of detecting ctDNA when it's at low abundance. And tumor heterogeneity that we just heard, such a wonderful overview of the challenges for therapeutic response. This is inherently affecting our ability to detect ctDNA as well because of different clones or other mutations that can exist at different proportions within cell-free DNA. So all of those present some challenges that are areas that are active research programs, such as my own, are trying to address. The biology of ctDNA release is thought to be related to dead and dying cells, primarily through apoptosis, also necrosis. There's some controversy about whether even active secretion of DNA from cells is contributing. And then once it's in the circulation, in terms of the possible contributing molecular aberrations that can help to distinguish tumor-derived DNA from healthy sources of DNA in the circulation. They're all listed here, but primarily point mutations have been the main focus of current clinical tests. Increasingly also copy number alterations and rearrangements are detectable. And I'll show you some evidence that DNA methylation can also be detectable and might have some specific uses and clinical utility. So another important aspect of ctDNA biology is it's very unstable in the blood, and it's likely the case because of circulating nucleases and also rapid clearance from the circulation through the kidneys and the liver. And so a couple of examples of this from surgically treated patients, either one with colorectal cancer, another with nasopharynx cancer, looking for mutant DNA molecules in the blood, or in the case of nasopharynx cancer, plasma Epstein-Barr virus DNA as a marker of tumor DNA. And you can see that after surgery, there's a rapid decrease in the levels of ctDNA with a half-life of about 30 to 120 minutes. And you compare this to many protein-based biomarkers or circulating tumor cells, and these kinetics are much more rapid, which could contribute to the use of this biomarker for rapid assessment of treatment responses, for example. Another fundamental biological attribute of circulating DNA is its characteristic size distribution. And this kind of small peak of DNA that is around 160 base pairs for people who are familiar with such things. The real take-home here is that this size corresponds to what we call a nucleosome, and this is a histone core, a core of 8 histone proteins with basically 2 loops of DNA around it. And this can be found circulating in the blood and really explains this characteristic size distribution. Another interesting attribute is that there's increasing data suggesting that the mutated tumor-derived DNA is slightly shifted in size, slightly shorter than healthy sources of DNA. The reasons for this are not really well defined, but it may present certain opportunities for detection. And I also put this slide up because it's really important for detection of ctDNA and the analysis methods that I'll talk about in the next few slides. This particular size distribution is very amenable to PCR and sequencing applications, as you'll see. So that will bring us to question 1. Okay. So summarizing the difference between ctDNA and circulating tumor cells. Can we make it a little smaller? Right. Okay, so I forget the first one. Did you see it? So thank you, yeah. So which of these ctDNA versus CTCs are detectable in urine as well as plasma, are more easy to store, are able to be grown in tissue culture to test drug responses, or there are available technologies to directly detect tumor-specific mutations. And then as these answers are coming in, I think you get the right idea. So we can move on, but right. So I point this out because, again, it's not the focus of this talk is not circulating tumor cells, but I don't want to leave them in the lurch here. There's certainly clinical utility that might be better seen with circulating tumor cells, but also on the research side, there's an increasing movement toward growing these in culture. We heard about that even from ascites fluid. And certainly that's an advantage of circulating tumor cells over ctDNA, which is by definition the product of dead or dying cells. So we can move on. All right. Okay, so a few slides on how we detect ctDNA. And just a summary here in terms of the various assays that are being developed. And you can generally focus or group them into single locus tests or assays. And these are generally PCR, either digital PCR or quantitative PCR, that look for a single marker. And I'll show you an example. And then there's sequencing-based tests, either targeted sequencing or genome-wide approaches. And we'll go over a couple examples. So first, in general, the targeted methods. And again, apologies, Mac to PC issue. So skip this, and we'll just focus on the droplet digital PCR. So quantitative PCR and digital PCR are kind of two different PCR approaches, but a lot of the basic premise is the same, that it's an ability to detect or amplify a single locus and a particular mutation. And just the way that droplet digital PCR does that or achieves that is slightly different from quantitative PCR, which was what I was going to show you there. Targeted sequencing, or next-generation sequencing, on the other hand, has the capability of interrogating simultaneously many different markers. And so that could be many different mutations, many different copy number alterations, or the similar different markers. And the two basic ways that this can be achieved is first by performing PCR and then sequencing these different amplicons in a pooled reaction, or by what's called hybrid capture sequencing, where biotinylated probes are used to adhere to or anneal to regions of interest, and those are pulled down and then sequenced. So this is akin to what many of you have may be familiar with, is hybrid capture sequencing for whole exome sequencing, for example, whereas amplicon sequencing is generally for much smaller targets, like maybe 1 to 10 genes, for example. So in general, the differences between the PCR-based approaches and the targeted NGS approaches are shown here. So PCR has the potential to provide excellent analytical sensitivity for one or maybe a couple of markers simultaneously. It's generally simple and of low cost, and there's mature technologies. Targeted NGS, on the other hand, the main advantage is the greater multiplexing capabilities. With that comes the potential for better analytical sensitivity, but there's also some trade-offs, such as more complexity of the assays, higher cost, and these are evolving technologies that aren't in the clinic quite as much. Now, how about genome-wide methods? So genome-wide sequencing can take advantage of the fact that these circulating nucleosomes, as I mentioned, could actually indicate where histones are residing on DNA. So if you basically just sequence all of the cell-free DNA, the way this group did a couple of years ago, there's the potential to actually compare this with published tissue maps of DNA and histone occupancy to deconvolve different tissues of origin. So for example, a cell-free DNA that's coming from lymphoid cells or myeloid cells or potentially different cancerous tissues can be distinguished based on these histone occupancy maps. This is all in the research space, though. Similarly, genome-wide methylation sequencing is also being explored as a way to deconvolve different tissues of origin. And groups have shown that, for example, using this approach, blood cells could be distinguished from liver or placenta or even cancer tissues based on methylation patterns. This is some work that we recently published on a cohort of about 400 individuals showing a proof of principle that you can use these methylation signals to distinguish between individuals with different types of cancer, including breast cancer, lung cancer, pancreatic, colorectal AML, and really just sets that proof of principle for future studies. Certainly more work is needed for gynecologic cancers in this space. Okay, so how about for actual clinical management? I mean, all these techniques, they're all interesting, but how are we actually going to help patients with this technique, with these techniques? So to give some examples, consider a patient treated with radiotherapy. This is close to home for me as a radiation oncologist. And patients treated with definitive fractionated radiotherapy will be assessed prior to treatment. And ctDNA, at that point is really the potential use as a prognostic biomarker. And the hope is that, at that point we can risk stratify and adjust treatment intensity perhaps, or even say, well, radiotherapy is not the right treatment for this patient and let's seek alternative treatment approaches. Now, during treatment, I showed you the rapid half-life of ctDNA, so there's excitement and interest in using on-treatment kinetics as a adaptive therapy guide. Can we use that to adapt therapy? Not yet, but people are working on these things. And then after treatment, the hope is that residual ctDNA taken after the completion of therapy could be a minimal residual disease marker that, if positive, could identify people who require additional adjuvant or salvage therapy, or if negative, could indicate that patients could be safely observed or treated with potentially a de-escalated adjuvant therapy, depending on the context. How about for surgery patients in the local regional management setting? Well, if that's the main treatment, and if standard of care, for example, is surgery only, then you might think that the main use could be in that minimal residual disease setting. Certainly, that's one potentially impactful clinical scenario. In other cases, standard treatment might already include adjuvant therapy, whether it's radiotherapy or systemic therapy. And in that case, the clinical decisions might be somewhat different, where the minimal residual disease biomarker could inform physicians about whether adjuvant radiotherapy might require additional systemic therapy in addition. Or for patients who are lacking that minimal residual disease biomarker, again, patients may be appropriate in that setting for observation, but this obviously has to be tested in the context of prospective clinical trials before any of this is implemented in the clinic. How about in the systemic management of patients? So there's a number of different settings that where ctDNA could help to guide therapy. First of all, just like in the local regional setting, it could act as a prognostic biomarker or risk stratification biomarker to guide adjuvant therapy or the duration, perhaps, of systemic therapy. There's the potential, because of the ability to detect specific genetic and epigenetic alterations, to identify markers of response or resistance. Maybe SYN, for example, could be detected. People are working on that. And in terms of guiding the duration or the appropriate time to change therapy, that is also a promising indication. And there's a lot of interest, of course, in the context of immuno-oncology agents to use kinetics of ctDNA to identify response and to distinguish pseudoprogression from true progression, for example. Okay, so that brings us to question 2. Okay, so based on the half-life, we talked a little bit about the kinetics of ctDNA. So testing for minimal residual disease after surgical resection should be performed after. And none of this is based on real clinical evidence, but just the concepts. So yeah, the crux of this question is how long should we wait, and what would be an appropriate time to wait, and the reason for that in terms of the half-life. So is it on the order of hours, or is it on the order of days? And how would that inform maybe a clinical trial that you might want to design down the road using ctDNA for MRD detection? Okay. So I made this one purposely a little tricky. I agree that I think the majority of people also selected D, but I kind of pushed the envelope here. So This has now been shown in a number of disease types that ctDNA half-life is on the order of just 30 to 120 minutes. Interesting also, fetal cell-free DNA is the same. But you might say, well, 2 days is still pretty early. If this is true, then in the context of surgery, then I think 2 days is actually probably a good time. Certainly wouldn't want to do it before then. But in practice, in the trial, you might actually say, well, I would like to wait, a little bit longer than this. And I don't know. That's for you guys to figure out as you go out and start to think about incorporating this into clinical practice. Okay. So in the last few slides, I want to share as a kind of a paradigm for gynecologic cancers, discuss HPV circulating tumor DNA, because I think it's a very convenient marker that we're using in this field and illustrates a lot of the concepts that we've already discussed. So it is very convenient because there's an 8 kb HPV genome that is part of cervical cancer cells, and generally not in healthy tissues, although there's obviously that's going to be qualified, I think, by our next speaker. And it's a double-stranded DNA genome, which means it's amenable to the same types of techniques that we just discussed. And it's present in cervical cancer at various copy numbers, a median of perhaps 10 to 20 copies per cell in cervical cancer, and that's the case across stages as well. So it has this potential amplifying effect then of detecting this in multiple copy numbers in a cancer cell. And in the clinical evidence for detecting minimal residual disease following local regional treatment has started to accumulate now, as you see some of the landmark studies here, for example, from nasopharynx cancer looking for EBV DNA, patients after definitive local regional therapy who have detectable EBV DNA have very poor prognosis. And similar findings have been seen in colorectal cancer, lung cancer, and I show this small study from oral pharynx cancer because this was HPV-related oral pharynx cancer, and again showing with very high hazard ratios, very strong prognostic effect of residual detectable HPV DNA after local regional therapy. So can this concept be applied to cervical cancer? Well, with my clinical colleagues, Dr. Kathy Hahn here at Princess Margaret and Eric Leung at Sunnybrook, also University of Toronto, we performed a small study just on 20 patients of local regionally advanced cervix cancer, that's HPV associated, confirmed by cervical swab, and patients were blood was collected at baseline, following chemoradiation, and then 3 months post. And we compared with clinical outcomes, but we were also curious about comparing with 3-month post-treatment PET-CT, which is often used and standardly in the United States for prognostication in these patients. So those were the kind of dual objectives of the study, and the methods we used were the digital PCR method that I showed you earlier, and we looked for both HPV 16E6 and E7 in a multiplex digital PCR assay. And this data is just showing you that the two copy numbers in patient plasma were nicely correlated with one another. And, so at baseline, all 20 patients had detectable HPV DNA, or I'm sorry, I'm only showing you 19 of the 20 because one patient failed on treatment, so was excluded for analysis. But 100% sensitivity at baseline, not surprisingly. But what was interesting here was that 6 of the 19 patients had detectable HPV circulating tumor DNA at the end of treatment. The 3 patients with the highest levels, unfortunately, had distant failure. Actually, all 3 of these had lung metastasis within 1 year. Also interesting was that there were 3 patients with very low levels of detectable HPV DNA who haven't progressed. These patients are still being followed, but pointing out that potentially in the context of radiotherapy, the end of treatment time point may be too early, and the specificity of this test might be too low at that time point. However, we did compare with FDG PET at 3 months and found improved specificity. There were certainly a number of cases, 7 cases, that had this indeterminate FDG uptake, and 5 of those 7 had undetectable HPV DNA. These patients, again, are continued to be followed, but so far the early indication is that HPV circulating tumor DNA could be a way to improve the specificity of PET. So that brings us to question 3. So all of the following, I missed it. Okay, are potential advantages of HPV ctDNA over FDG PET in the post-treatment assessment of cervix cancer patients treated with radiotherapy or chemoradiotherapy, except the ability to localize residual or recurrent disease, early assessment being possible with HPV ctDNA. HPV is maybe more tumor-specific than FDG uptake, and maybe it's more convenient. All right. So I agree with the vast majority that selected that first one. So, this is a limitation of HPV ctDNA in particular. You could think of ways, based on what I've shown you from the previous slides, that maybe in the future methylation could be combined with HPV ctDNA to help show tissue of origin information, maybe of sites of metastasis, but that's all very exploratory. Okay, so that's it. I just wanted to acknowledge the people who contribute to this work in my lab, Marco and Tracy in particular. And the cervix cancer study that I showed you is really being driven by Kathy Hahn as well, in collaboration with Eric Leung at Sunnybrook. And we have the opportunity now with a recent grant to expand this to other sites in Canada. So we're excited to validate these findings and continue to show clinical utility for circulating tumor DNA in cervix cancer. So happy to take any questions.
Thanks very much. Most interesting questions. Yeah, thanks. All right. Oh, I have a quick question.
Okay, good.
So to what extent for non-tumor related DNA, like obviously the levels fluctuate based upon disease burden, but like to what extent are we measuring non-tumor DNA, and how do you factor that in or exclude it, or is that just something we accept?
Yeah, so if you have a good marker, then you pretty much accept that that's tumor derived, but it's not perfect, right? I mean, you take HPV, for example. We know that there's certainly HPV exposure that will be present in the population that's not tumor derived, but for a particular patient with an HPV-related malignancy, whether it's cervix cancer or otherwise, I think over the course of treatment and shortly afterwards, we're basically assuming that all of the HPV signal in the blood is from the tumor in that patient.
I see.
I think until we find otherwise, that's the assumption that we're making, and that might be a flawed assumption. But it's an important question because, as I showed you in the beginning, the vast majority of circulating DNA is from other tissues in most cancer patients. In the setting of widely metastatic disease, that isn't necessarily the case. Like you can see ctDNA levels above 10% or 20%, but for most patients, it's under 1% of the total circulating DNA is from tumor.
So for most of the work, you're using like a mutation marker then that's indicative of the cancer as opposed to an epigenetic profile?
Right. So when you have an epigenetic profile that's more difficult to confirm or have confidence that it's tumor-derived, at this stage of research, it's useful to have some other orthogonal marker, like a mutation that's confirmed within the tumor to correlate to, and so most of the work we're doing, we have multiple markers to compare. But in the future, the goal would be if you have a very well-validated tumor-specific epigenetic profile, and I think we'll hear about some of that in the next talk, then maybe that's sufficient. But we're not quite there yet.
Right. Okay, thanks very much.
Great.
Sorry, was there somebody else?
Another question?
No. Sir.
Congratulations on your talk. It was very interesting. Alexandra Sebastianelli from Quebec City. On a patient's perspective, patients are reading a lot, and I've had a few patients asking me, well, why don't you take me a blood sample to see if there are like cancer cells circulating in my body and make sure that you killed all of them? So just a patient's perspective, and they know that this is coming.
Well, I certainly recognize that. I treat head and neck cancer with radiotherapy, and we deal with a very similar scenario all the time. And we have to wait 3 months to scan them, and we can't give them good answers. And so I'd love to get to that point where we can get a blood draw and give people more confident information. I think in general, we're not there yet. In a clinical setting, I encourage you to consider the appropriate clinical trials for your populations, because the technologies are starting to be there, and what's really lacking is the clinical utility data. So certainly that's what we're trying to build here and HPV is kind of convenient because it's a well-established marker and assay, and it's easy to implement. But the others are coming as well, and for ovarian cancer, P53 with the other components of SYN and other things, they will be next in line. So if we can show with HPV and cervix cancer that this is useful for a certain setting, I think it will be easier for the field to move towards other applications as well.
Thanks very much.